I'm also a professor of health communication and the director of the International Research Centre for Advancement of Health Communication, which stands behind the Master of Health Communication. And this afternoon or evening, we have the very great pleasure of a distinguished member of our centre, Professor Bernadette Watson, who's going to be telling us about the role of communication in health and the many factors that impinge upon communication, and that communication affects as a broad network effect within health. She's gonna talk to you for about 40 minutes, and she's going to hand over to me, and I'm going to tell you briefly about the Master of Health Communication, and we'll open the floor for questions for all. So without taking up any further time, I'm going to pass on to Bernadette, who has many years of research and practice in the area of health communication, and especially interprofessional practice. Thanks, Bernadette.
Thank you, Stefano, and it's lovely to be joining you all here. And here I'm sitting in Brisbane, and it's just gone 7 o'clock, and it's a nice evening. It's good that the time difference isn't very different between Hong Kong and Brisbane. So I apologize that I wasn't able to give this talk on the 12th, but as it turned out, I was traveling and got sick, and it was not possible. But anyway, here we are today, and it's being recorded. So if anyone couldn't make it on today, but would have made it on the 12th, they'll be able to listen and watch this talk, which is called Communication. It doesn't just happen. So let me give you a little bit of a background to this talk. The Master of Health Communication, as Stefano mentioned, is a new postgraduate program. And along with many colleagues at PolyU, I was involved in the development of the program structure. And the MHC places communication at the center of effective healthcare for health providers and for their patients. And that's what makes it a unique program worldwide. It's not often that you take communication as being a critical part of everything that's done. And I'm going to go into that a little bit more. But let me first start by saying, well, what do we mean by communication? Communication is a very wide topic. We can investigate hospital communication events by studying the different types of messages that are typically relayed in the hospital context and the medium used. For example, handwritten, spoken, electronic, or a combination of these. We can investigate the function the communication serves, whether it's about shift patient handovers, about assessing the patient, about discharging the patient. And we can also investigate the times of day when these communication events typically occur, as time of day is an important predictor of effective communication. We can examine less formal communication events, such as those conversations between health professionals about a patient's condition, as they occur in the corridor of a hospital. Added to this, there are the 2 a.m. calls for assistance from a junior staff member to a more senior health professional when they feel that a patient is deteriorating and they don't know what to do. Then we have the operating theatre, or operating room, as the Americans call it, which are different interactions again. And all this is before we even begin to examine the written medical records, which are a major part of communication and in which I've been involved over the years. Finally, and often not so thought about, the different physical settings of the hospital play a role in shaping the atmosphere. The actual hospital layout, the lighting, the facilities, all these will influence communication. This list of where and how communication events happen and the types of messages that are sent and received set the scene for the complex world of healthcare interactions. One aim of the MHC is to unpack all these issues and provide students with expertise from other disciplines to understand how communication functions. They may then be in a position to implement changes in their respective hospitals. We also need to look at the challenges in the healthcare setting. The healthcare hospital setting is complex. It involves multidisciplinary teams. We have adverse events, which I'll explain in a moment, that are not reducing after 20 years of intervention. And we can see that the current focus we will see is on communication skills and communication competence training, which, while critical, is actually far too narrow. Changes are needed, but how and by whom? What we know is managers who understand the hospital system and have learned good leadership skills will make a difference. So, the hospital setting is complex. Healthcare environments are highly hierarchical, and there are clear status and power differentials in the hospital. And we all know that doctors tend to be the top of the power differential pecking order. This has been validated time and time again by others from different social science disciplines and is agreed upon by health clinicians. Highly diverse professional groups all work in the same environment. Now, the reasons for the hierarchical and status-driven culture of hospitals is historical. But with today's requirement that different health professionals regularly interact together, it's becoming more problematic than it ever was. Alongside increased interdisciplinary engagement are the relentless shortages of staff and resources that are prevalent around the world, in particularly the public health setting. Resource shortages cause work pressures, and work pressures can lead to conflict. And we know that conflict exacerbates miscommunication, especially when there are power differentials involved. Communication failure between health professionals is far too common. In my work on communication handovers, which is when health professionals, before going off duty, provide the incoming professionals with the status of the patients under their care, has been recognized as a very serious problem when you look at the transfer of accurate and up-to-date information. The reasons for this include telephone interruptions and doctors being called away, the noise of the environment. Handovers or handoffs, as they're called in the States, can occur in busy ward areas and staff can't always hear each other. As well, some medical staff do not turn up, so there's a gap in information. Some staff find they're supposed to be at more than one handover at the same time, so they can't get there. These situations lead to miscommunication and can detrimentally, as you can imagine, affect patient care, as well as frustrate staff and lead to communication problems. The existence of hierarchies and power differentials are a big part of this problem. It is not possible for a junior doctor to demand that a senior consultant come to a handover, even when needed. The Master of Health Communication covers these problems and examines what can be changed, what is accepted as a norm, but actually is interfering with good health practice. Health professionals that I meet with know that there are problems, but they themselves are too busy and do not have the capacity or the competence to address the problems. They know what they'd like to see, but they can't do it themselves. So having a program such as the MHC that will highlight these issues will bring the students and the graduates into connect with health professionals, and they can help them sort out and maybe change some of these issues. Finding out what the communication events are and where they occur is a very important step. I've collected data from health professionals over the past 8 years or so, and I've collected it from Australia, the USA, and most recently in Hong Kong. This research focused on the barriers and facilitators to patient care. I've found remarkable similarities between the data findings across all 3 countries. So the problems that I'm discussing today are truly global. However, the way to resolve the problems may need a strong cultural understanding of each country. What works in Australia as an intervention may not work in Hong Kong. Thus, we need a program of study that informs students about global issues, but also acknowledges the differences between Asian and Western cultures. Too often, the Western culture has imposed its interventions on the Asian context without fully understanding or acknowledging the culture. And I can give you an example here of what I mean. So in my research across the 3 countries, it has been a constant that nurses will say that they often don't feel very empowered, that they could do far more, and that doctors tend not to allow them to be as effective and efficient as they would like to be. They would like more autonomy. Now, when Australians and Americans say this, they will say it in rather derogatory terms. Those doctors, they think they know it all. They tell me what to do. They treat me as just the nurse. And they find it degrading. In Hong Kong, the nurses also talk about wanting more autonomy, being recognized for the skills they have, but they certainly do not say things about those doctors, they make me so angry. They're very respectful and recognize the importance of the structure in the hospitals. So an intervention that might improve and empower nurses working with doctors in Australia or the US would have to be very different from one that's situated here in Hong Kong. There is a recognition and acceptance of the legitimacy of the power of doctors that is not so obvious in the US and Australia. And I think those kinds of differences really need to be examined carefully and looked at before interventions can be put in place. So examining the global problems and specifically investigating what can be done using Asian knowledge is one critical role of the MHC. Let me now turn to the fact that working in multidisciplinary teams in healthcare is challenging. The picture here shows a multidisciplinary or interdisciplinary team. There are many ways of describing these teams, and reflects basically how different disciplines come together to discuss patient care that will allow for effective communication between team members. These teams exist now more than ever before. Interdisciplinary teams are more common because of the many technological advances in medicine over the last few decades. These advances have led to people experiencing better quality lives, even though they have multiple health issues such as diabetes, heart failure, cancer. In fact, the list is endless. In earlier decades, they would have died from these illnesses, and they would have died much earlier. As we age, our health problems increase. And so this is also a consideration. Indeed, our aging population is another global issue that is adding to changes in healthcare and healthcare management. And these population issues are also examined in the MHC. Interdisciplinary teams have become an important part of managing patient care. More than one kind of expert and health professional discipline is required to manage these patients with comorbidities. These teams comprise doctors, often from a number of different specialties, such as renal or cardiovascular, together with nurses and allied health professionals. And they're all working together to ensure good patient care. But this change has not been seamless. Health professionals need to be able to communicate together in order to provide good patient care. But it would seem that with this emphasis on learning together, our problems with managing interdisciplinary team will be solved. There are numerous opportunities for different health professionals working together and why it should work well. If you've come from a different discipline, you can share your different views of knowledge. You have different expertise. You may also have different opinions on how a patient should be managed. There may be new concepts about care that some professions are more aware of than others. And everybody working together can expand their horizons and learn more. And indeed, when students do get the opportunity to work in multidisciplinary teams, which is happening a little bit more in universities now, they enjoy it. They like learning what physiotherapists do. They like learning how nurses manage healthcare. What about speech therapists? All these things are opportunities to learn. And it would seem that it would be a good way forward. But alongside all these opportunities and why it should be good, there are challenges. We can draw on the work of L'Oreal Lingard, who researches how well health professionals work in teams. She's noted that currently health professionals who work independently are very competent, but when they have to work collaboratively with different disciplines, they become incompetent. Why is this? It's because health professionals use different language and jargon across their respective professions. This is because predominantly, and it's still happening, they train separately. Now, there is a great push since the 90s for health professionals to come together for some classes and learn together and work together. But sitting in a class which has different kinds of health professionals in it and listening to the same lecture is not the same as knowledge of working together on a case. So there are still challenges. And it's also the case that when people train separately, they have a strong sense of their own profession and their own in-group, if you like, identity, and they see the other professions as out-group. And this can be especially true if one profession has a higher status than another. So what does this mean? Well, it means that health professionals prefer to keep to their own silos, work in their own professions. And this leads to what is known as a silo mentality. One profession doesn't share with another profession patient information. It's not deliberate, it's cultural. And not working collaboratively together can negatively affect patient care. Previous research I have conducted has shown that these factors really do influence how patient care is managed. These in-group formations affect the way health professionals communicate with each other, and this affects patient safety and quality. And one of the most common causes of poor patient care is this miscommunication. Now, there is a recognition that communication must improve, but the focus has predominantly been, as I'll show you, on skills training and communication competence. And that's too narrow. The bigger picture of the hospital context, which I've already shown you is very complex, is paramount if we are going to reduce miscommunication. Now, the response to try and improve communication between different health disciplines has been to try, as I've said, to teach communication skills. And this has meant putting in place checklists and communication tools that aim to reduce error and ensure a comprehensive system of patient care. Health educators in the hospital system have argued that providing competency skills training for health providers will improve their communication skills and help reduce error. So over the years, there's been a pattern of focusing on competence and skills training to fix failures. But what we do know 15 years on is that there's been no success in reducing miscommunication, and skills training has not done the job that we would expect it to. And this lack of improvement is despite the fact that countless communication interventions to improve communication between health professionals have been introduced. And I have been working with a colleague, Dr. Amos Young, and he and I have looked at the numerous amount of communications tools that are developed that really, at the end of the day, only serve to complicate matters. So currently, the communication skills training is far too narrow. And the scope of understanding miscommunication as a systems problem related to the hospital environment has not been investigated. One aim of the MHC will be to introduce theory and research that expands this notion of competency training to one that takes account of the complex hospital systems within which all the health professionals work. What is needed is a realization that there must be a focus on the big picture of the hospital system and the recognition that communication problems arise in specific contexts, and the antecedents of those contexts are just as important as the immediate event as it occurs. And I'll explain this more fully. So as I've said, hospitals are highly complex structures with many resource challenges. In addition, we now also know that health professionals do not always communicate effectively together. We also know that communication is critical because miscommunication can lead to patient harm. Patient harm, also known as adverse or sentinel events, occurs when the patient experiences harm that actually was unavoidable, avoidable and not related to their condition. And this harm can be mild, severe, or in the worst scenario can lead to death. Now, communication failure has been cited in 70% of events leading to serious patient harm. Research findings suggest that adverse events are preventable if we improve the communication. Yet with all the interventions that I've mentioned, adverse events are not reducing. So what is going on? Why are there no real improvements in reducing error? This again relates the focus on competency and training and not examining the hospital as a complex environment. We need to change the way miscommunication is investigated. We need health providers who can step back and look at each adverse event with its own merits and also look at the related antecedents of each event. This currently does not happen, and it doesn't happen because clinicians are primarily the ones who are involved in investigating patient harm, and they haven't had the appropriate training. Their clinical training teaches them to look at what's happening in the present moment. In patient care, they look at the current condition of the patient and make recommendations. Clinically, this is highly appropriate. But when patient error occurs, expertise is needed that takes a more in-depth approach, which includes looking at the pathways that led to the adverse event. Now, when an adverse event occurs, a report is made by all the staff involved. And a root cause analysis team is brought in to examine the incident, to find out what happened and make recommendations to ensure it does not happen again. But as I've said, they are not trained incident analysts. They are clinicians from different parts of the hospital system who are brought together to find out what happened. I apologize for the noise of the helicopter going over. Hopefully it'll only be just momentary, and I'll take a sip of water while it happens.
It's not really coming through the speakers, so you can rest easy on that score, Bernadette.
I'm having to be outside because of changes to the house. I hope that was a one-off. So the root cause analysis team is brought in to examine the incident to find out what happened, and as I say, to make recommendations to ensure it doesn't happen again. But they are, as I say, clinicians from different hospital professions who examine the reports, look at the event, and try and find what were the contributing factors, and then make the recommendation. In Hong Kong, I've investigated adverse reports over a 10-year period and have examined the different types of miscommunication related to these events. The table I'm going to show you in the next slide is from a paper I published with Ms. Ivy Wu, who worked on the research with me and is now doing her PhD at PolyU. It will show the category of the event, what the root cause analysis team decided were the contributing factors, and their recommendation. So here we have, first of all, the type of sentinel event or adverse event category. And we see that you can perhaps have the wrong you think you're treating a patient and it's not that patient. So you're actually treating the wrong patient, or you're treating the wrong part of the patient. So what if this has happened and the wrong patient has been operated on, or the wrong operation has been given to a patient? It was their left leg that needed amputating and the right leg was amputated. These are serious events. What caused it? What were the contributing factors? And as we see in this table, we have, it was reported a failure of a scrub nurse to speak up despite awareness of the mistake. And what's the recommendation? Reinforce the speak up culture among surgical team members. So he didn't speak up, so we've got to fix it by making sure that we reinforce a better speaking up culture. It's one of the most common adverse events for patients is actually leaving instruments and materials inside the patient after an operation. And again, well, what's the contributing factor? The contributing factor has been ineffective communication between doctors and nurses. So what should we do? Well, we should enhance communication between doctors and nurses on things like gauze packing and counting procedures, and reinforce team communication. Another reason for retained instruments and materials is ineffective communication, again, between doctors and nurses, and junior staff not speaking up when possible area was suspected. For this one, no recommendation was given. There was also a failure to escalate communication to senior staff about a patient problem. And the recommendation here from the team is, well, reinforce the transfer of critical information during handover among nurses and doctors, and ensure timely escalation of communication to senior staff when in doubt or problems occur. And finally, we have here the functional management and staff communication in the care laboratory was compartmentalized and not efficacious, and the wrong blood was given to a patient. So let's make sure that we reinforce independent interpretations of first and second blood grouping results. communication breakdown caused by misinterpretation, unclear instructions between nurses also caused blood incompatibility. So let's reinforce the importance of delivering clear instructions to avoid misinterpretation and encourage staff to speak up and clarify uncertainties. When you look at these reports, what's missing? These reports about the events are published and available to the public. It can be seen that even though a member of a team may have realized a problem, missing instrument, extra gauze, it was not uncommon that a person would not voice any concerns or doubts within the operating team. They remained silent. This fact was not taken up by the investigators in any serious way, apart from to say what they needed was to ensure a speaking up culture. But if it keeps happening, then this is a communication issue that needs to be more fully investigated. Studying communication more closely means that we need to ask what's going on. Research suggests the focus on miscommunication and its consequences by clinicians has led to this trying to fix the outcome mentality. But there is generally no consideration of the underlying dynamics that happen outside of the communication events. We have to ask what factors are in play and existed before that specific event, and perhaps are a constant that need addressing. Why are nurses not speaking up? Why are doctors not listening to the nurses? Why are mistakes being made? There are important antecedents to these events, but these antecedents are often too difficult for the hospital panel, the root cause analysis panel, to investigate, because the investigators are within the hospital system. So they don't really see how these things can be changed. They're actually within the system. And so they don't prioritize them. They just say this happened and this must be changed. So currently, health professionals' reaction to error and miscommunication is too narrow. I don't think it's realized just what a wicked problem we have on our hands. Rittel's definition of a wicked problem is that it's a social or cultural issue or concern that is difficult to succinctly explain and subsequently innately problematic to try and solve. It is too complex for any one solution, but that does not mean we cannot chip away. The recommendations by the root cause analysis team focus on improving communication. There's an assumption that health professionals have poor or deficient communication skills that can be fixed by skills training. My data suggests that many health professionals are skilled communicators, and they direct their communication behaviors so they achieve the outcomes they desire. I would like to raise one other issue that I think is problematic when we're looking at this healthcare setting, and it relates to communication skills training. In universities and hospitals, where competency training programs are rolled out to students and health professionals respectively, there seems to be an explicit acknowledgement that engaging in communication training is about teaching a soft skill. I went to a talk some years ago by Professor Shrikant Sarangi, who is director for the discourse of practice at the Danish Institute of Humanities and Medicine and has been involved with the MHC. He stated very clearly, and I agree, that if we tell clinicians to whom we are teaching communication that it's a soft skill, then clinicians no longer take the subject matter very seriously. But it's not a soft skill. It requires a lot of work to understand how to communicate to someone about their particular situation. One person's diagnosis of an illness and what it means for that person is a unique situation. My research suggests that the challenge lies in ensuring health professionals are made aware of the context in which they interact and the antecedents that they're seeing as status quo. Communication researchers in the MHC are well placed to provide this knowledge to their students. So let me recap for a moment on what I've covered. I've said that health communication is highly intergroup, different groups of professionals working together, and it's complex. Miscommunication has become a focal issue because of its relationship with adverse patient events. The consequences of miscommunication have been emphasized and have led to fixes around communication training as a soft skill. But nothing has changed. Antecedents to the outcomes are not sufficiently acknowledged by health professionals. We need to educate professionals to delve further into these recurring behaviors. And these are topics that the MHC will introduce, and it will mean that those already working in the health sector who undertake this program of study can learn new ways to approach the above problems and become advocates for change from the inside. The MHC aims to educate health professionals to understand it's not only about a specific incident where an error was made and there was an adverse consequence and outcome for the patient, but it's about the precursors that can lead up to that event, and are they the same precursors that keep on happening, in which case the recommendations are not skills-based, there's something else going on. So what can be done? We need to recognize that communication is a complex problem, and as I keep saying, skills training is not enough. I'm not denying the importance of skills training, but it's not enough. We also need to know there is no one solution, and highlighting complexity would be a first step. The MHC unpacks the complexities that health professionals face. It challenges students to view problems from other perspectives. So we must recognize that the MHC can actually play a very important role in changing some of these behaviors. My research again suggests that working relationships with staff can make a real difference to whether or not patient error occurs. You could have a situation where all the variables appear to be the same. People are working with staff shortages, lack of resources, staff are tired, there's inappropriate responsibility given to junior doctors, and they're dealing with too many patients. But in one situation, we'll find the patient care is successful, and in another, we'll find a problem occurs. So the same, more or less identical situation with the same challenges has a different outcome. If people are working well together and have trust and respect, and there is strong and appropriate leadership, bad decisions can be avoided. So what is apparent is that the role of effective leadership is also key. One of the subjects in the MHC focuses on what leadership means and recognizes the types of leadership and how to provide leadership training. A big problem in the hospital system is that health professionals are promoted to management and leadership positions without any formal training. They have to learn on the job, and occasionally an individual may have good leadership skills, but it's not common. Managers are required to solve problems. That's what managers have to do. And they need to be role models, but they have to be taught this. And this is another aspect of the MHC. And this next comment is from a nurse, and it highlights what many, many health professionals have said and what I've just mentioned. So maybe my take on things is a little bit different, but I think that leadership is so important and it can make or break a department, because you can have bells and whistles and a beautiful department, but if you do not have happy staff, that can really impact on the running of the department, because it's teamwork and you've got to keep the team united and working well together, especially through rough shifts. So that emphasizes again something that the MHC will highlight. We need to train our MHC students to consult with their clinical colleagues and to highlight the relevant environmental issues that exist. They will be in a position to do this because they are working in the hospital as well. Change must come from within the hospital system, which is what the MHC will provide. Once we have strong advocates within health across many levels, we can move to a state of activism, and such activism can bring about change. So what is needed in sum? Awareness that communication issues are complex and situation specific. There has to be a concerted commitment from a number of players for change to occur. And no one discipline has the answer. Shared knowledge is important, which is why you have different subjects being taught in the MHC, giving different disciplinary approaches and sharing knowledge. And finally, I'd just like to say that in the data that Ivy and I collected in Hong Kong, all these issues came out from the health professionals. They recognized the organizational factors that got in the way or facilitated healthcare, from shortages of staff to fatigue to poor resources. They also were aware that communication with others and levels of trust, empathy, and rapport really mattered if you wanted to have good communication between staff and patients. And they highlighted that there has to be a focus on leadership and its relevance to good patient care and staff well-being. And really that is everything that will be embedded within the MHC. Now, I'm going to stop there. And I thank you for listening, and I'm going to stop sharing my screen and hand over to Stefano, who's going to talk a little bit more about the actual aspects of the components of the program.
So so we're just gonna, you've heard a lot about the philosophy of the program. Just to sort of, to reiterate, what we're really talking about is a program that takes a systems view of communication as a system. We're not trying to teach you how to communicate, as Bernadette has been emphasizing, in a narrow sense in terms of communication skills. We're giving you the empowerment and the skills to examine the situation within the systems in which it lives, to take the situation, take it apart, understand it, put it back together so it works. That's the real focus of this sort of program. So it's a fully online program because we know that a lot of health professionals are particularly busy and need to be able to do the program from wherever they find themselves. And of course, this is why we're able to offer it internationally from Hong Kong. It's tailored particularly so that you can choose one of the two paths, which I'll talk about in just a second, one being the more research focused and one, of course, being obviously more coursework focused. And choosing those paths is completely in your domain. There's no, it's just literally a choice of how to fill in the bulk of the elective part of the program. And so really you'll get the same core communication content if you choose one or the other. Then of course, given that we're taking such a strong systems view and we're looking at communication as a whole approach, we do have a heavily interdisciplinary focus on health and communication. So of course, we're coming from an English and communication department, but linguistics, psychology, health informatics, which is a big area of expertise at PolyU in general. So you've got access to a lot of that here, and also, of course, some advances then in a connected way in computer science. We have say the academics from the department who'll be mainly teaching in the program include myself, and you've already heard something about me, and also Professor Louise Cummings, who's got a lot of expertise in the neuro side of communication, linguistics and communications disorders, as well as the applied part, which is public health. Dennis Tay, who is an expert in metaphors and mental health care communication, especially the communication that occurs in the therapeutic situation, in the psychotherapeutic situation, and Dr. Margot Turnbull, who's been doing research in health literacy, who's got a qualitative public health background. We're going to be focusing really on an understanding of what health means, as you've been hearing about, to different groups, and particularly going to be looking at cultural differences in terms of illness and health. And of course, then that broad-based understanding of how health-related communication is actually communicated in different modalities and in different registers. They all have a different impact upon health literacy. And then, of course, as I've been saying, developing your knowledge and skills as practitioners in a systems way, in a way to help you take apart the situation and put it back together so it works. So in terms of giving you time to be able to ask the sorts of questions, these are some of the people in the department in which the Masters finds itself. We've got a range of world-renowned researchers. We're currently ranked 75th in the latest QS World Rankings in linguistics. And of course, as you can see, the expertise of the department is strongly tailored to applied communications areas, language and professional communication, of course, language teaching and learning, applied linguistics, media and communication, and intercultural communication. All of these areas in some way will be represented within the Masters. Now, the mode of the program is, as I said before, completely online, and it's in a part-time mode. So it will normally take people 3 years part-time, which again, we've set up, and I know that Bernadette did a lot of work in this, talking to practitioners prior to setting this up, because we understand that people are primarily going to want to be able to do this while they're doing a full-time job. And it's generally not really tenable for people to be doing this program in a full-time way. So we really tailored it to a part-time. You need ultimately 30 credit points in order to graduate. So there are basically two ways to get it. One is, I guess, what you might call a sort of standard master's approach, where you have your 7 core subjects that's worth 21 of those 30 credits, and you take 3 elective subjects, and I'll show you some of those very shortly. The other way is the research path, about which we've just spoken. So you take 7 cores, 1 elective, and of course the research project, which then counts for 2 of the electives, and you can do research with any one of the staff members of the program on a topic which is of relevance to health communication. So this would be particularly useful for people who find themselves in a workplace with a situation, especially that involves a communication system, that would be amenable to an intervention or an analysis as a sort of research project. You'd be able to do that in conjunction with a supervisor and actually derive immediate practical outcomes as well as a thesis. Again, the 7 core subjects, of course, are exactly the same across either approach. Now, here are the subjects. So we have critical thinking in healthcare issues. We've got organizational communication, specifically in the health context. It's not just organizational communication per se, but within the context of health. Similarly, leadership and communication in the context of health. Managing effective health communication across modalities. As Bernadette was saying, there's an increasing amount of communication is spread across the many different channels that are available to people in the contemporary world, and certainly in the contemporary world of health. As is always important, we will be covering research design and methods to help you be better consumers of research and be able to understand and critically evaluate the sort of information that's out there for you. We'll be taking a more of a problem focus, looking at understanding issues in healthcare communications across professions. So that's the interprofessional side that we've been talking about. And again, to take a more systems view, we're looking at health and social policy. So these are the compulsory subjects that together make up the package. In terms of the electives, you're able to select from practical communication strategies 1 and 2, intercultural communication to deepen that side, communication more generally. So there's a misprint there. Psycho-oncology for health professionals. That's one that I'll be taking. I've been researching psycho-oncology and with prostate cancer for a long time. Also health stigma, which again is largely enacted and represented in many ways through communication. Communication is the broad net that makes these things occur. And of course, the research project. So these are the subjects. The tuition fee, of course, so per credit, that's 5,900 Hong Kong, which is about 760 US, and is about just over 1,000 Australian, and that's the same price for local and non-local students. In order to satisfy the entrance requirements, again, they're fairly standard in terms of master's degree. You need a bachelor's degree or equivalent from a recognized institution. We suggest that people be employed or have work experience in the healthcare context. And that's not mandatory, but clearly we've pitched this program and we've set the program up around the needs of people who are working in the healthcare context in different areas. We know that a lot of the interest is from certain clinical groups and people who are working in hospital management and administration. And finally, in terms of the English language requirement, you need to meet one of the following, which is either the standard tests, the TOEFL, with the scores of over 96 in the internet test, or as you can see, they're 590 in the paper base, or of course, a 7 in the IELTS. If you don't have either of those that are sufficiently current, of course, we can examine your sufficient competence in English. If you have a degree from a university using English as a medium of instruction, we can discuss your English competence at an interview and a written test, which we would set. So, of course, there are 3 different ways to meet the English language requirement. I'll put, this is the name of the admin person to email or call for the further information. I'll put that in the chat too, so you can copy and paste that as required. Here's the chat. And that's Trace Cheng. And so, and then finally, that's the website, which of course has also already been put into the chat. Thank you all for having joined us, and thank you especially to Bernadette for making it through her illness and giving us such an excellent talk, talking about all the great research that she's been able to do.